Recording. All right, go ahead.
Okay, so we're going to follow on from the previous lecture and looking at the further causes and management of severe maternal outcomes. So the objectives of the lecture are to recognise the symptoms and signs of pulmonary embolus, amniotic fluid embolus, sepsis and influenza, to understand their anaesthetic management and the role that they play in the morbidity and mortality of pregnant women. So these are figures from the UK Confidential Inquiry into Maternal Deaths, and as you can see, the figures for thromboembolism have not decreased over the past 10 years. This is thought to be because of the increasing obesity rate in the UK, because this is on the background of a mandatory guideline to try and reduce pulmonary embolus in pregnancy. So if the patients weren't getting fatter, the rate would probably have gone down, but because of the rise in obesity, it hasn't. As you can see, the rate of amniotic fluid embolism is pretty steady as well. So yesterday we quoted a paper from February's edition of JAMA, and here is an edition from 1941, which was regarded as a landmark article where the phenomenon of amniotic fluid embolism was first described. We haven't really come a lot further in the past 70 years in understanding the cause of it. Thankfully, it's very rare, but it has a case fatality of up to 60%. It's unpredictable, you can't identify risk factors, so it's not preventable, but it is important that uterotonics are used in safe doses when they're being used to augment or induce labour. The patients present with a catastrophic maternal collapse. They have hypoxemia, hypotension, and they most notably, which is what gives you the diagnosis at the time, get a massive sudden onset of DIC. They have a biphasic cardiac failure picture. The treatment is immediate delivery of the woman if she is still pregnant, and it is important that you trigger the major hemorrhage protocol at the same time as you make the decision to do the perimortem section, because these patients will bleed. So it's a diagnosis of exclusion. It's important that you've excluded causes such as hemorrhage or PE. So it's acute maternal collapse with any of the following, as you can see: cardiac arrest, coagulopathy, hypertension, and some hemorrhage. But of all of those symptoms, the three that are most important are the coagulopathy and the hypotension and the collapse and the shortness of breath. So the confidential inquiry emphasises that the perimortem section must be carried out within 5 minutes of the collapse. If you actually try and practice this in your hospital, it is very, very difficult in real time to do the perimortem section at 5 minutes. So it's very important that you have a scalpel available on your cardiac arrest trolley or cart. The treatment is merely supportive, that is oxygenation and treating the cardiac dysfunction, the heart failure, and trying to improve oxygen delivery and tissue perfusion. So it is a rare but devastating cause of maternal collapse. If we move on to pulmonary thromboembolism, this is the leading cause of direct maternal deaths in the UK. It's also a significant problem in Palestine, and with your repeat caesarean section rate going up and the BMI of your patients increasing, and the fact that many of your women are smokers, this is going to become an increasing problem within your country. If you take a non-pregnant woman who's age matched and compare her to a pregnant woman of the same age, the pregnant woman is 4 times as likely to have a pulmonary embolus or a DVT. We talked in the initial lecture on how pregnant women are designed to clot more easily as a protective mechanism in labour. However, in the context of modern society, with obesity and smoking and immobility, this goes too far and puts the patient at risk of pulmonary embolism. It's absolutely essential that women are risk assessed antenatally and given prophylaxis. And if you can refer back to the second lecture, you'll see a slide with all the risk factors and the type of prophylaxis that the patient should be given. It's also part of the WHO checklist, which certainly in the UK we perform before every cesarean section. So you need to be thinking, has this woman had any anti-embolism prophylaxis? The symptoms and signs are widespread. They may classically present with leg pain and swelling on the background of having a risk factor, for example, a long bus journey or a plane journey. However, they can present with lower abdominal pain if it's a femoral or iliac DVT, low-grade pyrexia, shortness of breath, chest pain, hemoptysis, or collapse. The symptoms may be vague, but it is very important that if there is any suspicion that the patient may have sustained a deep vein thrombosis or pulmonary embolism, that they are treated with low molecular weight heparin until the diagnosis is excluded. The diagnosis of DVT is by, in leg DVT, is ultrasound. If it is suspected to be in pelvic veins, a venogram, or if you have access to an MRI, an MRI. For the suspicion of pulmonary embolus, the woman needs to be given a chest x-ray. The dose of radiation that she sustains from the chest x-ray is negligible and put together with shielding of the fetus. It should not hold anyone back from performing a chest x-ray on a pregnant woman. The definitive diagnosis is a VQ scan, or if you have access to a CT scanner, a CT pulmonary angiogram with contrast. You can consult this document, which is available on the internet, about the acute management of thrombosis and embolism. But the bottom line with it is that you must treat on clinical suspicion and not wait for the diagnosis to be made. Because if you don't treat them on clinical suspicion, you're putting your patient at risk of having a serious adverse outcome from sustaining a massive embolus. So again, a massive PE causes maternal collapse. The treatment is, of course, airway, breathing and circulation, but specific to the treatment of pulmonary embolus, they need to be given IV unfractionated heparin, as opposed to the low molecular weight heparin that you use for the regular treatment. You may wish to consider thrombolysis. This is difficult when you're dealing with the fetus and the placenta, but if it's going to be life-saving, you're probably going to need to deliver your woman anyway. You may need to involve a thoracic surgeon to perform a thoracotomy, or you may wish to do a surgical embolectomy. If a woman has repeat deep vein thrombosis, aside from the treatment of the massive PE, you may wish to put a vena cava filter in to offset the pulmonary complications from the repeated DVTs. Moving on to sepsis, a quarter of the women who died in the last confidential inquiry in the UK died from sepsis. And essentially the message with the treatment of sepsis is early diagnosis, rapid antibiotics, and the involvement of the most senior people available. Sepsis is defined as the presence of infection, whether that's proven or suspected, with systemic manifestations of infection. And severe sepsis is sepsis plus organ dysfunction or hypoperfusion. Pregnant women are particularly vulnerable to sepsis because they are immunocompromised in order to deal with the fetus. Now, sepsis and pregnant women is a very old topic. Semmelweis, who promoted hand washing in the beginning, did this on a background of noting that women who delivered in hospital got puerperal fever. So, puerperal fever is a very old-fashioned term for genital tract group A streptococcus. The sepsis sources may also be respiratory, that being influenza or pneumococcus. In the second trimester, it's mainly ascending coliform infections, and the patient may present with meningitis, including meningitis from a pneumococcus. If we look at this graph, you can see that, as I've described, the top two are E. coli and group A strep. Group A strep is a big killer of women worldwide, and it's the most common postpartum infection. It can gain entry from the vagina, it can gain entry at caesarean section, or it can be transported to the uterus via the blood. Postpartum, there's a 20% increase in group A strep infection rates compared with non-pregnant counterparts. And the patients present with very non-specific features, and they progress rapidly to decompensate. And it is the non-specificity of the sepsis symptoms that cause confusion and delay in the diagnosis. They may complain of myalgia, fever, confusion, dizziness, and abdominal pain. And they are at risk of getting group A toxic shock syndrome, which is devastating and often fatal. So, the symptoms and signs of sepsis, they are familiar to you, but we will go through it again. So, pyrexial or hypothermic, a heart rate of more than 100, a respiratory rate of more than 20, and a raised white cell count or a low white cell count. SIRS, systemic inflammatory response syndrome, is confirmed if any two of the following are present. So confusion, the temperature criteria, increased heart rate and increased respiratory rate, along with abnormal blood sugar and white cells. And sepsis is an emergency, and one must act immediately if the patient is hypotensive, if they're extremely tachycardic, if their oxygen saturation's down, or they are very tachypneic, or they have a decreased level of consciousness. This situation is an emergency. The woman is on the edge. Well, the woman has already decompensated and may die unless the correct action is taken. So, this is a worldwide campaign, Surviving Sepsis, and the information is available at this web address, survivingsepsis.org. And it starts with the simple basic things. Any pregnant woman or recently pregnant woman who says she feels unwell must have her basic observations taken pulse, blood pressure, respiratory rate and temperature. If there is a suspicion of sepsis, in the same way, if there's a suspicion of a pulmonary embolus, you need to give the antibiotics within an hour. There needs to be a fluid challenge to see if this improves the BP and the pulse rate, and you need to involve the most senior clinicians available. There is a strict protocol available at the survivingsepsis.org website, but essentially after the initial treatment of taking blood cultures, giving antibiotics, fluid challenge, you then need to look at goal-directed therapy for your cardiovascular parameters and your urine output. And this needs to take place in a obstetric high dependency area or in intensive care itself. So the package is known as the Surviving Sepsis Bundle, and there are specific goals which can be audited in your establishment. So, if possible, measure your venous lactate, get blood cultures, give your antibiotics. The antibiotic you give will depend on your local protocols, but you need to bear in mind what you think the suspected organism is, and to give a fluid challenge to correct hypotension. You then need to move on to vasoconstricting your patient and putting invasive monitoring in. And it is the antibiotics that are absolutely key to halting the progress of the sepsis. So if we look at some case studies from the confidential inquiry, we see a woman in the first trimester who had a sore throat. She went to her family physician and was told there was nothing to worry about. She presented 24 hours later with diarrhea, vomiting and feeling unwell. She was hypotensive and tachycardic. She was seen by a junior doctor 3 hours after admission, and they didn't realise how serious her condition was. She was seen by someone slightly more senior 6 hours later and prescribed some antibiotics, which weren't given for over an hour. So this woman had been in hospital for 7 hours before she'd been given her first dose of antibiotics. She deteriorated and died a short time later. Second case is very similar, except the patient was postnatal. Post-section, she was hypoxic, unwell. It's thought that maybe she was having a hemorrhage. However, the diagnosis wasn't made, and again, all too late, and she had signs of strep A at post-mortem. However, it's not all doom and gloom. For every one woman who dies of sepsis in the UK, pregnant woman, there are 14 pregnant women who survive severe sepsis because they are treated promptly and correctly. So this woman was 7 days after a vaginal delivery. She felt unwell, at home with a fever. She went to the hospital. She had her vital signs taken straight away, and she was prioritised as being seriously unwell. So a diagnosis of acute sepsis was made. She had antibiotics, her uterus was emptied, and she was treated in the high dependency unit, and she survived. So the simple approach of measuring people's vital signs, understanding the seriousness of deranged vital signs, and following a simple protocol of giving antibiotics early and resuscitating your patient with fluid pays dividends and will save people's lives. So moving on to influenza, it's an acute viral infection of the respiratory tract. It presents with fever, cough and shortness of breath. It can be either influenza A which includes the variety H1N1 or influenza B. There's been a global pandemic of influenza, and certainly in the year 2009, it was responsible for a serious number of maternal mortalities in Palestine, as well as in the UK. So, a woman presented during the H1N1 pandemic, and it was not recognised that she might have influenza, and she died. So again, this is an example of not following the basic procedure and not having a high enough clinical suspicion of what might be going on. The most simple way of preventing influenza is to vaccinate your women. 1 in 11 of the women died. Half of these people could have had the influenza vaccination, and they didn't. So another example, a pregnant woman who smoked, she was offered a influenza vaccination by her family physician. She refused it and then presented a bit later with H1N1 and died within 24 hours of admission to the intensive care unit. The uptake of vaccination is low. In the UK, it's about 25%, despite the fact that it is offered to every pregnant woman. So every encounter that you have with a pregnant woman, or your obstetric and midwifery colleagues have, is an opportunity to ask the woman if she wishes to get vaccinated. Treating influenza, it's a very highly infectious virus, and the viral load is concentrated in the endotracheal tube. So the people looking after these women need to have suitable protection for their own health, and the need to protect the ventilators and tubing that the patient's connected to. Although neuroamidase inhibitors are not recommended as routine for the treatment of flu in non-immunocompromised patients in the UK, they are recommended for the treatment of pregnant women because of their immunocompromise, that being Tamiflu and the other varieties of it. You just have to give organ support, so respiratory support and any cardiovascular or renal support that's needed. In the UK, there are a few centres that do extracorporeal membrane oxygenation, but things are pretty dire if your patient needs ECMO, and obviously this is just a very specialised facility available in certain countries. So, flu is preventable. It needs to be recognised. You need to give your patients neuroamidase inhibitors, and they need to go to intensive care. So, in summary, if we look at the embolic phenomena, sepsis and influenza, pregnant women often present with non-specific symptoms. When they decompensate, they do so rapidly and drastically, and diagnosis begins with clinical suspicion and the measurement of the vital signs. You need to rigorously implement the sepsis bundles, and you need to involve the most senior clinicians available to look after the woman. So thank you very much.
All right, questions? Questions? All right. Well, we hope you have a safe trip, Julia. Minus the without any of the without any of the harassment by without harassment
Yeah.
by the Israeli authorities. So, anyway, all right. No questions. Outstanding. I think somebody should start thinking about the influenza immunization in Palestine, at least for pregnant women and elderly patients and so forth. Right. Wonderful. Thank you very, very much, Julia. I hope this will not be your last visit to Palestine. I
Right,
think
thank you.
you've done an absolutely outstanding job. And
Okay.
have a safe trip.
All right. Bye.